All right, so Tim Lant. Tim is giving our keynote today. So when the team started planning out the conference, it was obvious to me that we should get a keynote speaker that was involved with the COVID pandemic. If to me, if there's any silver lining into the stuff we've been going through since March, Lev talked about data literacy. I think of how many people are more conversant in data now because of what's happened with COVID. I mean, looking at COVID charts, I go to the New York Times and look at the state by state charts on there. People talking about R naught, right? And what's the transmissibility of this? Probably wasn't in most people's lexicon before March. A graph pops up and you're like, hey, is that a logarithmic scale or a linear scale? Let me check that before I go in. Hey, when you said percent change, is that percent change or change in percentage points? Because those are two really different things, and I'd like you to clarify. I love this. I think there's so much that's been done to make folks more data literate and data conversant. So I asked a couple of colleagues, I said, hey, who at ASU knows COVID data, healthcare data? And the answer came back as Tim Lant, without any hesitation. So we're very fortunate to have Tim here. Tim is a director in our Knowledge Enterprise group here at ASU. Prior to ASU, he actually spent 5 years at HHS, at the Department of Health and Human Services. So when we talk about national preparedness for a global pandemic, as they say, Tim was in the room where it happened. And so I'm very fortunate to have him here as a speaker. I know there are others on this group that are fortunate to be able to work with him on a weekly basis when we look at our COVID data, our testing data. Such a wonderful opportunity for us to have him here. So Tim, I am going to pass it on to you, but during his presentation, we will have lots of time for questions afterwards. Feel free to put questions in the Zoom chat. And we'll queue those up. But Tim, I will pass it on to you.
Sounds good, Mike. Thanks. Appreciate it. Appreciate the invitation to come and talk to this group. I've been scrolling through the participant lists, and 283 people on a Zoom call on a Monday morning is pretty impressive. I recognize a lot of names. Either I've worked with you in the past or you've specifically been part of the cooperative effort that we've had going on here at the university really since December and January, when events began to unfold in China. Let me get my screen share set up here for you. All right, so I'm notorious for putting together way too many slides, so I'm going to go through this quickly. But as Mike said, here's a little bit about my background. I have been in Maricopa County in Tempe, Arizona for about 22 years at this point. I came to ASU in 1998 to go to graduate school, and I keep leaving and coming back. So my last tour of duty was working for an organization called BARDA, which was the Biomedical Advanced Research and Development Authority. That's within Health and Human Services, and it's the part of Health and Human Services that had a modeling division, which I helped to grow up for a number of years. And we were responsible for emerging infectious diseases, pandemics, bioterrorism, nuclear terrorism, chemical terrorism. So when we hear about Operation Warp Speed and the work that's going on right now with government investments in vaccines for COVID, this is sort of the center of it all. So we were in DC and worked in the building diagonally across the street from the United States Capitol for a few years. And really, one of the main things that I did there was to advocate for bringing data sciences into more of an operational role in the government. It's something that's extremely difficult to do. It's hard because it's not really a scientific enterprise, but it requires one. It requires being able to tap into that. It's not really an operational role because you have to work with subject matter experts and have a lot of knowledge about the specific problem. So I want to talk about that. But first, what I want to talk to everyone about is the Iszs. The Iszs is going to be the monster that I've chose to pick on for the purposes of this talk. Iszs have been around, I think, since the early 1990s. They're often found with the protagonist named the Max, which is a big purple dude with yellow claws. Characteristics of the Iszs, they're unintimidating. They can self-replicate. They have very sharp teeth. They're white or black. Occasionally you'll see a red one. They can change size very quickly, and they're quite moody. What do Iszs have to do with the COVID-19 pandemic? Well, it's not really a surprise to see one. They can be particularly unpleasant. It's worse when they surprise you. You can choose to ignore them, but it never ends well. And data can be extremely useful to fight them off. So hopefully I've attached to the theme of this meeting, and you guys can all appreciate that Iszs are something that we should work into our monster repertoire. So, all right. So the pandemic was not a surprise. Pandemics have been known for a long time within the public health community, the epidemiologic community, modeling community. They're constantly occurring. People have hypothesized that they occur like sunspots on 10 or 11 year intervals, but that's generally been false. But they could emerge at any time. It's known that they could emerge any time, and it's known also that the risk of a global pandemic is among the worst risks that our planet could face. During 2002, when the SARS-CoV-1 disease was originally discovered in China, we basically, the world was not able to contain it, but the disease moved slow enough that we were able to slow it down. And then ultimately, it did go away after 2 years. It was around for 2 years. We had a couple thousand cases of it. 2671 as of April 2003. There were another couple hundred cases into 2004. But that disease was contained. Of course, it wasn't completely contained. The viral mutations that occurred over time led to it resurfacing back in December. So this is an academic field that's been around for a very long time. It is an interdisciplinary field. It is a data-heavy field. Epidemiology in itself is a very, very data-heavy field. And there's some very specific data issues that occur with epidemiology. But I want to talk about a brief history. So the hypothesis that we're working under here is that government leaders will apply scientifically informed interventions, including the provision of scientifically vetted and accurate information for the public to use, or for the public in order to save lives and protect property. This is the mission of the government. This is what they're supposed to do. This is what everyone assumed they would try to do. Doesn't necessarily mean that this is always going to happen or that this is trivial to do, but we should look at least a little bit on sort of how we got to this point and how the government has sort of lined up our data assets in order to take care of pandemics and a whole host of emerging situations. So back in 1964, the height of the Cold War, secret government bunkers operated computers with support from the Lant Corporation to inform decision makers. This was documented for the public in Dr. Strangelove, or How I Learned to Stop Worrying and Love the Bomb. And in it, there is a scenario that unfolds where the United States and Russia basically engage in nuclear warfare with each other. And the decision-making constructs and the modeling constructs are all laid bare for everyone to, to participate in. You had to have a special invitation to get in. You had to be a little bit crazy in order to succeed in this environment. But here we are. It worked for a few years, but then in 1983, we changed up the format, and our hypothesis moved a little bit towards one where computer simulation and deep AI will lead to safer and more healthy communities. Many people are still operating under this paradigm. The National Science Foundation has recently announced new initiatives in this space. And there are even applications where technology that clearly emerged directly from Matthew Broderick's 1983 film War Games are being applied to fight off the pandemic. We have other examples that emerged. Around 2005, the framework shifted a little bit to let's model everything. There was an application built, funded by the Department of Energy out of Los Alamos National Lab. Very famous modeling application where they put together the transportation network of the United States. They modeled every individual, billions of agents all interacting with each other and spreading disease, in order to make sure that we had a robust capability if there was actually a pandemic, that we would have a computer system that would be able to predict where it was going to go, and therefore we would know what to do. This system was the predecessor to significant National Institute of Health investments into modeling effectively as a cottage industry, meaning that there are a dozen or so universities around the country that have very sophisticated modeling groups. Occasionally, those groups are going to engage with public health departments, but not necessarily. And this is it. This is sort of the way that our country currently deals with modeling for pandemics. So a few modeling groups that are connected to the government, but more often than not, modeling groups that are academic institutions that require connections to local and state health departments, some federal information sources, and a variety of things. But it's not something that you can really just sign up for and get on a pathway to participate within, within a 4-year degree or something like that. It really is something that's nascent. You have to navigate it. And one fantastic way to do it is as a data scientist, because really data holds a lot of this field together. So what is it like working as a data scientist in this field? What is the role of the effective use of data analysis and models in the public health emergency preparedness environment? So the first thing is that this is not, again, I'll emphasize this is not a field that people can just step into when there's a pandemic and be good at it. There have been a lot of what are called in the community armchair epidemiologists, which are folks that literally say, here, hold my calculator for a second, I'm gonna go save the world. And some of them did a reasonably good job for a limited amount of time when dealing with data constructs and other things that they were good at. Others of them have really upset the modeling community, have said some things that are absolutely ridiculous, and made it difficult for really exceptional models to have avenues to support their work. But I think overall, it's been a pretty good process. It really requires close collaboration between modelers, decision makers, and subject matter experts outside of the modeling space, in particular with epidemiologists, doctors and other clinical providers, nurses, anyone who's a frontline COVID worker. And then there's a broad and robust, outlet for research literature, which now includes pre-publications through the Med Archive. But people are going to publish in this field anywhere from Science and Nature, New England Journal of Medicine, PLOS ONE, really all over the place. So it's not like there's really a journal outlet for people to work in this field. The problems are messy. They used to be called wicked problems. The paradigm still works. They really have to be modeled, or they have to be managed. Usually modeling assignments, you start on one thing, you work on it for a couple of weeks, you answer a question. Once that question is answered, you may or may not have a need to have an operationalized database that someone continues to, to clean up and feed with data and report results to and inform some process. It may just be that a decision is made, some kind of investment occurs, some kind of program is established, some kind of decision happens, and then people go on, and that sort of is a branch in the road that once taken, it's hard to come back and revisit. So it's best when models answer specific questions. Not all models work. Some models can get rejected. And it really requires sort of building a process around the modeling activity. There's lots of examples of this, both with internal and external stakeholders that we could talk about, and we will talk about. Projections for the state, working with the local counties, helping ASU set up their testing program. All of these different components have had to come together in a way that's operationally relevant. So what is this taking? Epidemiological analysis obviously requires very good competency in data handling and data wrangling and data cleaning. We talk about epidemiological modeling and outbreak science. In the health policy sector, we have to understand health policy analysis and what it is, what motivates it, what principles are the most important. We've had to look at health and medical data analysis. Health data sets are usually owned and operated by the state health department and then shared with CDC. They're not owned by CDC. They are injected from medical data sets, so we're dealing with a lot of issues around HIPAA, PII, anonymization of data, aggregation of data, and then some new capabilities that are necessary only in pandemics, such as case investigation, contact tracing, isolation, and the community response. And then for operational subject matter expert support, we've relied on Outbreak Science, Public Health Preparedness and Response. We did some rapid threat casting as a different predictive technique, and then logistical support. So these are areas that our team has had to basically fill out. So we have a core team of about 5 to 8 people on any given Sunday, and then we build out in these other capability areas to make sure that what we're doing is connected to reality. Policy context for research at the intersection of modeling and decision making. It's complicated, and in 2020, it's been, I think, more complicated simply because a lot of the constructs that would have been available to connect modelers and the academic community back to the public health community are in a little bit of a state of chaos right now. A lot of the organization's connection points have been unhooked, and a lot of the pandemic planning efforts that really begin at the federal government level and then cascade down through state health departments, through county health departments, through other science organizations. The plans simply weren't there this year. They were discarded earlier on, and so it's been a system to navigate that really doesn't have a rule book. And without having a rule book, you have to sort of invent as you go. But what has worked really well are people that knew the plans and remember the plans being able to interconnect with each other in a variety of different ways. So we've made these connections. The preparedness investment that requires having timely and rapid scientific information for surprise events also requires having standing capabilities, having infrastructure, computers, hard drives, people who are familiar with an area of science and can handle data, and also people who are able to move very quickly. So my partial luxury during this pandemic was simply having the ability to plug in directly with the university, with a number of different organizations in order to start working on this issue. And a lot of the investments that ASU has made over the last 20 years in having the sort of the technology backbone in place has been enormously helpful. Uncertainty and behavior frame most response decisions, and with epidemiological data, tremendous uncertainty. All of the data is missing, all of the data is dirty, all of the data has sensitivities around it. And being able to have an approach that's part art and part science to understanding data sources and their uncertainties is absolutely foundational. And the folks that got it wrong, they got it very, very wrong, had some pretty bad days, and I think have done a lot to learn this lesson. So what are the central challenges here? This slide I pulled out of a presentation I gave at the Institute of Medicine probably 10 years ago, and it's just as true today as ever. So absent data, huge challenge. The delusion of false precision. So when dealing with sort of, scenarios of future courses of outbreaks, trying to understand and measure down to the individual level how many cases or how many hospitalizations are going to occur is almost impossible to do with data. But the way that the data constructs work, you're always going to get answers like this. So answering questions as appropriate when they're order of magnitude or ranges is an important tool, and can often help with a number of different issues around the decision making that the data informs. Predicting free will is a huge challenge. Trying to predict in January and February whether or not we were going to have a mask ordinance by the time we hit April and May, and then the peaks in June and July, whether or not people would comply with the mask ordinance, whether or not people would take the disease seriously. And then the big wild card was when the modeling itself had to start to account for people who believe that the pandemic is a hoax. And the behavioral outcomes of that is absolutely a monumental challenge. The visualization of scenario space is a challenge. Not everyone is familiar with reading the different types of data products that we can produce. and it requires taking the time so that people gain familiarity with them and can start to generate their own heuristics from the data that are correct. Having a public expectation for preparedness. Okay, so foundationally, what is the government's role? What are different institutions' roles in terms of, protecting lives, protecting property, and generally being able to act quickly and be prepared. The elicitation of values and priorities. So how do you know what people care the most about? That's an important modeling question. The difference between plausibility and probability is also important. Just because something might happen doesn't mean that it's likely to happen. And just because you understand probabilities for very low probability events, something being plausible can lead to different thinking and different outcomes for how analysis is performed. And then the justification of investments. Anytime that there is money at stake and models are used in order to inform decisions about resource allocation and prioritization, it's not uncommon that other stakeholders want to put their thumb on the scale and can do this in a variety of different ways, including questioning model credibility or questioning credibility of data sources in order to favor particular model results over others. So let's talk a little bit about outbreak science. How is outbreak science different than just epidemiology, and how is outbreak science something that was useful for us in terms of having an early understanding of the COVID prevention or the COVID outbreak? So the first is applying social science and historical perspectives to outbreaks is important. They happen in similar ways. You can see here's a flyer from 1918 saying that a gauze mask is 99% proof against influenza. Wear masks. Face masks are being required. This graphic here shows the all-cause death in New York City in 1918 compared to all-cause mortality in New York City in 2020. And you can see there's a very similar pattern where there's basically stable levels of mortality, and then there's a pandemic that occurs. There's a giant spike in cases. So this is historical understanding, but it teaches us some very important issues. This photograph, this very famous photograph of one of the isolation units in 1918. And what's important to keep in mind is that the medical situation in 1918 was very different. We really hadn't invented antibiotics yet. So when people were developing pneumonia and sepsis, we had very few treatment options for them other than rest. It's obviously very crowded. So despite the fact that healthcare has changed so significantly, we're still in a situation right now where the primary prevention, the primary mitigation that we have against COVID is non-pharmaceutical interventions. So social distancing, hand washing, face coverings, all things that don't require a medical technology to be put into your body, either as treatment or some kind of pre-exposure prophylaxis, such as a vaccine. So this is important for modeling. And then public health preparedness and response is also part of a general preparedness cycle. Again, if we want to do work in the data science of pandemics, it's really hard to pick up a program or pick up even a pencil for the very first time early in a pandemic without understanding and going through multiple different public health situations and scenarios in the past. So there's a few of those that our group has really good knowledge of. One of those is the Assistant Secretary for Preparedness and Response Hospital Preparedness Program. A second one of those is the CDC Public Health Emergency Preparedness Program. So these are public programs that fund the investment of all of our preparedness initiatives across the country. There's also very specific federal roles and responsibilities in terms of who does what. At the federal level, some of these were followed during 2020, some were not, but Health and Human Services, of course, has a role. CDC has a role of doing surveillance and providing guidance. National Institutes of Health has a role in conducting research on medical countermeasures. BARDA has a role in doing advanced research development, production, and distribution of medical countermeasures, including therapeutics and vaccines. State governments have a specific role in terms of conducting surveillance, running testing programs, helping collect data, and then supporting counties. Counties have a role in contact tracing, notifying people who have disease. Also, they have a surveillance role. And so all of these are effectively programs that have some data competency. It's very important data competency. They're running with large daily systems with daily production, daily reporting, and a lot of interconnectivity between the various systems. And then there's also, there's programs for exercise design and execution, which also can be very data heavy if done well. There are exercise programs around the country and many institutions where they practice running fake events to see whether or not we have a plan that can work for them. So, so that's some contextual context framing, high level. This is what it, this is what it feels like and seems like to be a data scientist working in this space. But of course, let's see some of the key events where we were able to use data science, where our team, we're generally called the ASU modeling and epi team. And so we got involved early on. So I just want to run through a few quick vignettes to show, what are the kinds of things when you're working in this space. So flashback to April 29. April 29 was a very, very busy week for our team. We had recently been called up for duty with the state health department. They were looking for some help with making projections for what the case levels were going to be in the state. And there was a lot of uncertainty at the time. We still were in a period where it was unclear if we should be wearing masks or not wearing masks. We just decided that we should be wearing masks. We had decided that we should have closures. So basically everything shut down. There was a lot of controversy about whether or not nail salons were an essential business or not. But schools were closed down right during spring break. And we were in sort of phase 2 of modeling response, which is try to figure out the scope, level, and severity of the pandemic so that we can tailor the response appropriately to what we expect to see. So this slide is very important to modelers. All modeling projections generally have some kind of disclaimer on them. And it's taken me years to learn why. But if you want to briefly read this disclaimer, the projections are not intended to be predictions or quantitative guesses about what will actually happen in the mid-range or long term. You're intended to show current trends projected into the future and relative effects of changes in transmission, social distancing, weather sensitivity, current burden of disease, and other epidemiological factors. As more testing, tracing, and isolation come online and policy behaviors change, the estimates will change. This is important for epidemiologists more than any other garden variety of modelers that I know, specifically because what we generally do is make predictions. It's just that the predictions depend on so many assumptions that it's almost hard to call them predictions anymore. And it becomes an art form of choosing a combination of assumptions and facts, gluing them together in a way that's useful to highlight what can happen as a result of policy decisions or human behavior. So it's super fun. Putting predictions on a table during a pandemic is also somewhat of an academic blood sport. There are winners and losers, and losing is bad. So, so back in 429, we are continuing to see an increase in cases and more testing. This is what my group had to say. Not everyone agreed with me at the time. Phases to opening up America again. We had just come out with this document about a week before, and it's this nice little policy manual that came out from the White House that said if you want to reopen again, you should have a decreasing number of cases, you should have adequate testing, and your percent positive cases should also be decreasing. So I took these statements at face value and I said, all right, well, we've been decreasing for about 3 days. I said, you know what, maybe the definitions that we're using for all of these criteria aren't completely well defined. They're subject to a small amount of interpretation, but maybe we should just get that cleaned up really well. And so I said, all right, well, here's the rules. We're at day 3 of 14. Soonest day that we can open up is May 11. If we do a really good job. And I thought this was a nice statement to put out. Some people were interested in seeing it. Some people were not, but basically said, if we all behave well, if we all do what we're supposed to do, then we can put a timer on this bad situation. We know that we'll be able to go outside again and play with our friends around the middle of May, which would be great. We increased the intensity of social distancing measures in March. So we had a little bit over a month of experience, all staying at home and not going out to parties with our friends, or going to the bar, or going to the gym, or going to get our haircut. So policies were in place. Key policy drivers had become public safety, underreporting, severity of disease, and potential summer effects. So we weren't even to the point yet that COVID was a hoax, and all of the other problems that occurred. All right. So here's what we were looking at a state level. This is the state's data dashboard. We received daily data sets from the Arizona Department of Health Services. So we had pretty good visibility into what was going on. We update forecasts from ADHS and commercial lab testing data, hospitalization data, and experience of other states and counties. So a variety of different reference points to do this. Monitor testing data and public health interventions as the basis of estimates. And back on April the 29th, we had a total of 254 cases on that day. There were 304 deaths in Maricopa County, or in the state of Arizona to date. So the data was all here. We had a total percent positive, around 9% of tests. So overall, people were worried, but this was a pretty bad situation. And then one of my favorite models, saying this facetiously, was the Institute for Health Metrics and Evaluation out of the University of Washington. And this was their forecast on April the 29th. The conclusion at the time was that we had reached the peak on April the 7th in terms of deaths. Cases were decreasing. We basically should expect everything to be taken care of and wrapped up by, let's say, May the 21st. By May 15th, we were having 1 death per day, and then everything's taken care of. Containment strategy has worked. Definitely June, July, August, everything's done. This was the prediction. And this was the consensus prediction as well. A number of people during this period of time effectively asked me why I was continuing to produce models when we had COVID Act Now and IHME. The White House was using these. We basically were able to follow the pandemic. We knew what was going on. Everything was fine. Don't worry about it. The CDC released pandemic planning scenarios. These are actually around in April. I grabbed an update from September. They continue to put these out here. And this had the range of disease parameters that CDC had already figured out in collaboration with the academic community of models, which I participated closely with. So I'm just as culpable here as anyone else. And academic publications started coming out. We started finding anomalies in the CDC data. They had what's called a case fatality ratio of 0.004. And in China, the fatality ratio is more like 2%, not 0.4%. So we started getting some fishy data from the CDC that put me on alert, because it didn't make common sense. And then we started building out what I think the public has seen more and more of over time, which is that when you're dealing with a disease, not just COVID, but any disease, what you generally see from a public health perspective, surprisingly, is just the tip of the iceberg. So you generally know when people die. It doesn't mean that it's necessarily attributable to the thing that you think it is. And with COVID, this is still the case. Death reporting takes a couple of months. And you know who's in the ICU. You definitely know people that are put on a ventilator or have a serious case. Those are handled in hospital reporting systems. But there are a bunch of cases where, due to the guidance at the time, people couldn't get tested. Even if they had symptoms of COVID, they had to have a known exposure to a confirmed COVID positive case for a 30-minute period of time within 6 feet. Otherwise, the test would not be available to you. There was even a period of time that ADHS stopped recommending COVID tests for people who were hospitalized with COVID symptoms, saying that they were, it wouldn't matter because they were going to be treated in exactly the same way. So knowing whether or not they had COVID was not important. All of these data points, all of these things that we knew about problems with the testing program informed our model through the absence of data, but not everyone was able to figure that out. And as a result of that, people that were assuming at face value that the data was complete made a lot of spurious projections. So we modeled this out. This is a little bit technical, but basically this is sort of a standard epidemiological model. It shows that people are susceptible and then can have some kind of exposure event, which lasts for a couple days, and then they can move into either a pre-symptomatic or an asymptomatic state. People that are pre-symptomatic tend to stay there for a couple of days. 3 days in a symptomatic state, we started to see evidence that people shed virus. Even while pre-symptomatic, we still were just early on getting information that there was an asymptomatic state. It was questioned if people could transmit when they were asymptomatic. So all of the data, all of the literature, the combination of local Arizona data plus clinical data from around the world helped us clarify all of these different points. So we came up with reasonably well-tuned models for what was going on in the state. But there was one huge issue, an absolutely huge, positively huge issue, which was that with all of the cases that were undetected, we didn't know what proportion of cases were detected. And so we had to figure that out pretty quickly. And initial estimates that we were around somewhere between as high as 30 undetected cases originally for every known case, but then it dropped to around 10 to 12. Subsequently, it's dropped. The number of suspected unconfirmed cases right now is about 2 to 1. We think about half of cases go undetected. We looked at the downward trajectory proportion of positive tests. This gray bar here indicates 14 days, which is how long we were supposed to have a decreasing trend. Certainly, this is not what I would call a decreasing trend. And we were able to also show, again, by taking logarithms of the exponential growth curve, you can see that if this is basically a straight line and it changes to a different straight line, that there's a change in trajectory that we were able to pick on. And so we sort of started honing in on what the transmission rate actually was. And then we pieced it all together and we came up with low, medium, and high estimates for the number of cases. These cases are a little bit below, but you can see that our models effectively showed that we anticipated an increase in transmission through the end of May for both infections and hospitalizations. And then we assumed generally that there would be some kind of seasonal effect, which we didn't get very much of. It certainly didn't seem like it at the time, but with the resurgence in cases that we're now seeing, you'd really have to question that assumption and think about how to handle a seasonal effect. So we put this out there. We shared this with the academic community, with modeling partners. This was somewhere between like heresy and blasphemy to everyone that we talked to at the time. They thought we were crazy, but still it was out there, and it seemed correct. And so we built a number of different scenarios looking at a best case scenario, a moderate transmission scenario with no underreporting, which we knew was wrong at the time, a best fit scenario, which assumed that we knew about a quarter of the cases. There's information about a transmission rate, the change of transmission, what summer effects would do. So we had a variety of different models, a limited reopening scenario and a late testing scenario. So all of the public health controls that we were aware of. And so we put all of this out there. And So this was, this was a culmination of, all of the data that we had from the state, data that was coming out from every state in the country. We were looking at places like Italy, looking what happened if our trajectory looked similar to theirs and thinking about all of the reasons why. Yes, this did in fact use data from China. It used data from Italy. It used data from early places in the United States. But the first studies that came out were in fact all primarily Chinese data. The Chinese data was trusted because it was produced through very rigorous academic peer review, the articles that actually came out. So there were significant databases. There were questions about whether or not we should be trusting the data from China. What I can say to that is that there are both reasons to mistrust Chinese data or to be concerned about trusting Chinese data, but not in ways that were dissimilar from our ability to trust US data. A lot of the data in the US was, there are subtle ways to control the timing and release of data that we had here. And without speculating that there was any kind of misdoing, all of the data had to be viewed with a critical eye at this point in time. And a lot of what that meant was reliance on known academic leadership who do high quality epidemiology work, who are publishing and participating with studies. So trust could be found simply by making sure to be very careful with the sources. We got it right pretty on. So these were our scenarios. This is what we showed. Again, the consensus was that we had already passed the peak on April 7th and that we would have a couple of cases in June, but there certainly wouldn't be anyone that died after June. And so we put in May 15 for reduction in transmission, said summer effects are not yet known. And then we did 3 excursions: a slow opening, a moderate reopening, and a fast reopening scenario. And so I just sort of read this graph out loud to a few people. Some of them happen to be senators and mayors, but we talked through this, and I said, it appears to me that of the 3 scenarios we're looking at, the only one that doesn't lead immediately to exponential growth is the slow June 1st lower transmission rate scenario. That one is manageable, while the other 2 scenarios, if you reopen, will lead immediately back to exponential growth. So here they are. So the blue one would be bad, the orange one would be bad, and the green one would probably something that's manageable, but we still showed that yes, in fact, the disease doesn't go away. There's still a significant number of cases here over time. So then on May the 4th, we had a press conference, Governor Ducey had a press conference with the director of ADHS, and they decided that things were looking rosy enough that we could go ahead and reopen everything. And then within the next 4 days, we had 5 of the highest case counts occurred literally like the day after they decided to reopen the state. I found it appropriate to put some of the less happy Iszs in this slide to make sure that we're consistent with the theme of slaying data monsters. We wrote this up in a pre-publication article so that everyone had access to it. And the punchline here is that at some point around July, I came back and actually plugged the data in to see what happened and how our model performed. This seems to be an important thing to do in situations where you might be right or wrong. And April 29 is here. So this is when we made these projections. And you can see that we didn't open on May 1st, but we opened somewhere between May 1st and May 15th. It was actually the 4th. They made the announcement of reopening. It was scheduled for some time around in here, but it was sort of phased in based on the different kinds of businesses and new business rules. And then we watched cases increase exponentially through the month of June and into July. So that was a very public story. I won't go into the details here, but there were some articles that are still around in Arizona Republic and other places explaining what happened in sort of the collaboration between the state health department and the tri-university modeling team. Antigen testing. So here's another data monster that came up that sort of illustrates the need for both subject matter expertise and also careful data work. So on September 17th, ADHS announced the state was going to begin including antigen testing and case counts. So there are multiple kinds of tests, but the two main kinds of tests are PCR tests and serological tests. The serological test is a blood draw. You analyze the blood and you can tell whether or not someone has COVID antibodies, meaning that they had the disease at some point in the past and still have active antibodies against it. So this is a good way to know how many people were sick in the past. It doesn't tell you if you have any kind of active infection. In fact, you have to wait a couple weeks after you recover from a COVID infection for the serological test to work. The other kind of test is a PCR test. That's what we do at ASU in the saliva-based test. This is a gold standard. It tells whether or not someone has an active infection, even if they're pre-symptomatic but shedding virus. And then a new kind of test came along, which are the antigen tests. The antigen tests are rapid tests. They're specifically designed to tell whether or not a symptomatic person has COVID, not an asymptomatic person. And so we now have a couple of examples where these antigen tests have let people down, specifically the White House super spreader event, and a lot of the athletic programs around the country use the antigen test. That's what they have access to on a daily basis. So using these antigen tests can be quite misleading. You can have a number of positive cases that are missed, which would reduce your percent positive rate. So if someone wanted to keep a percent positive rate artificially low, one way to do it would be to release a lot of antigen test results. And they also don't pick up asymptomatic people, which are also known to transmit the disease. So ADHS started throwing these in with the data reporting, and of course, our models predict positive cases and outcomes. So this would have led to a pretty significant change in our model. Fortunately, on this one, the modeling community was pretty active, and a few folks were outspoken and said, why are you doing this? This doesn't make any sense. It's a different kind of test. It gives you different information. They shouldn't be combined. The CDC recommended to do this and did this themselves at the same time, and pretty much the entire national epi community decided to take to Twitter and say, that's dumb, don't do that, please stop. So they did. But you can see here what you get is you get spikes in cases that artificially show. So for Maricopa County and then for the state health department, you can see that you have a spike in cases here simply because we increased testing and started finding a lot more. So it obscured the trends. It's also true if you test more, you find more cases, but it's also true that by changing the kinds of tests that you're giving, you can manipulate data in that way. And this is a harbinger for some of the hospitalization data, which gets even worse. Why is this such a monster? Reporting problems caused by system updates, overwhelmed staff, meaning that if staff don't have time to report cases and it's their job to report cases, those cases can rack up, and 6 or 8 days later, they might get entered, or a couple weeks later. Double or misreporting by hospitals, which actually absolutely happened at one point in time. Urgent care was reporting into the hospital system instead of the urgent care system, which is an example of a misunderstanding about definitions. So a whole bunch of things can happen here. So the change in data just on one day, so this is a phenomenal curve. Literally, we got out to October 5th, and ADHS came back in and removed all of the red data from this data set. So we're trying to predict basically reported data, because that's what you have to try to predict. Well, the data itself had a time lag that could work in both positive and negative directions. So taken overall, this is what the hospital reporting data looked like, which is also why our group got it right and most other groups really didn't understand what was going on. This black curve here was all of the data that was reported up until the end of July. And we were hearing anecdotal information that the emergency rooms and the ICU units around the state were filling up really quickly. And then over the next couple of weeks, there was a series of data backfills because the records finally got processed through the data system that cumulatively led to this overall curve. And if we had known that this was all the overall curve, all of the models and projections and everything else that we were looking at, all of the data sources, obviously would have changed very, very, very significantly. And we would have been more alarmed than we were at the time that we went through these events, when basically things were open, but there was no sincere talk about going back to more austere measures for a while. What does all of this do? So these are the epidemiological rates. So that the idea was, initially we would want to use clinical information from China, Italy, Europe, New York, any place that had practices that were the most compatible with what we were doing here in the state. So this is the data that we'd want to use, but as you can see, the data was completely unreliable until we had adequate case information. So, so anytime that you saw a number of hospital cases that came in through back reporting, it causes this green curve, which is the probability of death given hospitalizations, or the hospital case fatality rate. And there would be a bunch of hospital cases that were reported all at once. They report deaths through a different system, so those arrive faster. And you get these massive drops in the various rates. This one goes up because it's the probability of hospitalization given a positive confirmed case. So if you report a number of positive confirmed cases, that changes the denominator of this. So, overall, these are just, it's not really a major grievance. It's just part of working with this kind of health and epidemiological surveillance data. So my personal wish list to improve quality and decision support models for policy. Obviously, we want better data and models, better model inventories, innovative competition of ideas, methods, and practices. You need the right people at the right time. Better analytic methods for testing alternatives in scenario space, visualization of outcomes under uncertainty, decision support frameworks and systems, incorporating normative frameworks into modeling and decision-making processes, iterative elicitation, probes, exercises, and other gap-filling processes to help communities of people work together, not just on the data products themselves, but the systems that the data represents, and then ongoing communication, sharing, collaboration, and dissemination. So I want to talk a little bit just about the ASU community of care. This has been a tremendous effort at ASU. A number of you have been helping the university out, helping me out, helping each other out with this. So I just want to talk a little bit about what the role of our group has been. So the first thing that we do is we produce a daily epidemiology report. It gets published on the ASU, on the management page. If you want to look for it right here, the COVID epidemiology situation report. I've put a link to it there for anyone that wants to follow along with the epidemiology. There's a few options to do this. Obviously, you can use the state's webpage, you can use the biodesign trends page, or you can come here for this report. This is a collection of the epi graphs that myself and my team put together because it's the way that we like to look at the information. It's not necessarily right or better. It's just different, but it's intuitive to us. So this is available as a resource to everyone. I also wanted to show current projections. We continue to update our model. So we updated again towards the end of last week. And in terms of where we are right now with the epidemiology, based on the current fit of the transmission rate, as of last week, we have a pretty significant exponential growth curve here. The transmission rate is 0.215. The highest it ever got was 0.225 back when we were in the surge. And you can see that we're anticipating with undetected cases somewhere around 37, 38,000 and people that would be infectious at any point in time. So it's not the number of new cases, it's the total number of people who are infected. We're seeing that hospital rates are rising again pretty significantly in a way that's not dissimilar from where we were back in June. So our projections are estimating that the current trajectory, we're going to have around 2,500 hospitalization cases, but that number could increase due to the uncertainties, up to around 3,000 by the first week of December. This is really not reflective of incoming cases from Thanksgiving yet. They will just start to be incoming at this time, depending on how much family visitation we see, how much travel we see over the holiday period. And then for the projections for the total recovered, we're at about 10%. The reason this is important is because there's talk of herd immunity. Herd immunity is when enough people have already become sick, seroconverted, assuming that reinfections are minimal. We know they happen, but we don't know how fast they can happen. This means that we would need to go through, to get to 70%, we need to get through about 6 more waves that are equivalent size to what we've already been through in order to reach herd immunity. That's a public health plan that's completely unacceptable. So hopefully we won't be doing that, but that's where we are. This is also confirmed by serological studies. And then we also have the campus plan. So all of us are participating as being within a sample pool of people who can get a mandatory test. This is extremely important for understanding the true level of disease, because there's a huge bias on people that come in and get a test either because they have a known exposure or they're symptomatic. So scientifically, this is an absolutely fantastic program, an absolutely fantastic information resource. I've said before, I'm like a meter maid on a power trip when I get to do this, because sampling people and making them go take a test is, it's about that level of, I guess, I don't know, thoughtfulness. But the information systems requirement, what we've done is we've worked with a number of you. The point and click, which is the new CLIA data system that's run out of student health. We use the health check data. We're doing work with several of you looking at also some Wi-Fi data at this point, and then we have access to a limited subset of information from the ASU faculty, student, and staff database system. So we have had to put all of these pieces together in order to come up with the algorithms and the programs to test everyone. So you can see basically what we're doing. The majority of people are off campus. That's just because that matches the demographics of the university. And the yellow ones are the on-campus students that are sampled. So this lets us piece together the epidemiological information. This is a little bit dated at this point, but it gives you an example of the kind of information we do. Where on a daily basis, we can see the prevalence on campus, which are these yellow bars, and then we track the % positive in the data. So actually the same information that we were tracking for the White House plan at the state level, we're doing that same thing for ASU now. So it just gives leadership enormous visibility into the emerging epidemiology as it unfolds here. So overall, I'm very pleased and proud to be a part of a university community that does this rather than one that's struggling with this, because not everyone has been able to figure out how to do this like ASU has yet. This is our team. Megan Jean is an epidemiologist. I've worked with her since about 2006. We went through 2009 H1N1 together and did a number of pandemic exercises at the Decision Theater, and have had a number of research projects with both the state and the county health departments over the years. As Miguel is a professor in operations research and industrial engineering in SIDSI. That's me back before I had a beard when I worked in DC. Heather Ross is she has her doctorate in nursing. She's a nurse practitioner and public health expert. And then Anna Muldoon is a colleague of mine who also worked for the Assistant Secretary for Preparedness and Response within Health and Human Services. She's a health policy expert. She's worked a lot on the Select Agent Program and emerging technologies for health and biosecurity. And then thanks to a whole bunch of groups. So my immediate team has been fantastic. UTO has scraped up a ton of data and worked to get that data into the program. The Biodesign Clinical Testing Laboratory for their ability to run samples, manage the data with those samples, and then push data out to connect back to the university's programs. EOS is running the entire management framework. They work with the students to make sure that the students stay in compliant, that they understand how to take their test and what the expectations are on them. KE Research Computing has been enormously helpful in helping to set up an environment that has the HIPAA protections and the security protocols that are necessary. Technical assistance with setting up databases, setting up software, moving files around, and also taking on the role of running the university's Honest Broker program, which is a partnership with the state health department. Our thinking here is that the state health department is willing to share on a case-by-case basis data sets that are useful for research. There's a number of rules to follow, but that's a capability that I think we'll be able to expand in the future so that we can do more research using these restricted data sets, as long as we have the appropriate policies and procedures in place to make sure that everything is handled the way that it should be. The ASU testing committee, there's a whole host of people around the university that are working on guidance and policy and execution for the overall testing program, not just for the university, but for the state of Arizona. And then just many, many, many other people have participated in a variety of different ways at different times. So a big thanks to everyone. That's my slideshow, and I was told that I had 1 hour. I finished 3 minutes early. So I'm happy to jump back on camera and start taking some questions from everyone.
Thanks, Tim. That was awesome. That was exactly what I was hoping to see, just lots of just data rich from someone who's been on the inside. So got a lot of good questions. So I'll go through them. And for the folks who asked the question, I'll mention your name. If I mangle the question or if Tim doesn't answer it to what you were asking, feel free to unmute and pop in, but obviously let's everyone be cognizant of being unmuted for the whole group. So I just actually want to start with one. You mentioned in an early slide, you had rapid threat casting. That
Yep.
sounds both awesome and scary as hell. What is that?
Yeah, it is. It's really cool. So ASU has a futurist. His name is BDJ. I think it stands for Brian David Johnson, although my nickname is Boogie Down Johnson. I refer to him only as Boogie Down. He runs a threat casting lab that does a whole host of work, and his methodology aligned with some of the more outside of the box thinking that we are able to do. So we ran through a collaborative threat casting experience with him earlier in the pandemic. We basically predicted a lot of the bad things that happened, including like suppression of science and manipulation of data, information and misinformation campaigns for political reasons, some of the problems that the federal government was going to have, with Tony Fauci and Deborah Birx. So, we got all of that on paper back in like April. The process itself is you go through and you basically leap into the future. You have a few key dimensions that you try to explore, and then you have to look for triggers and flags and other indicators that these things are happening. It's really eye-opening. Boogie Down is around. He's extremely smart and helpful. So if anyone is interested in learning more about threat casting or what the process is or seeing what we did, I'm happy to help make connections. I'd highly recommend it, and it's something that we're hopeful that we can continue to do in a variety of different areas.
Thanks. You said that was Brian David Johnson. What department's he in?
He's in SFIS.
Got it. Thanks. Melissa asked that in the chat. Well, there's a question that's related to what you just said. Susie had a question. Do we need more social scientists involved? Because you have behavioral issues, it's a hoax, it's freedom, I'm anti-vax. So as opposed to just pure data people, what role does social science play in this?
So yeah, social science is huge. I effectively have, my credentials are in technical areas. I mean, I have a PhD in applied math, but almost everything that I've done, going back to when I got out of, just pure math had a social science component to it, or multiple social science components to it. I'm a huge advocate for including social scientists in all of the work that I've done. Modeling really has a very different flavor to it when you inject social science into it. It's how our projections are right when everyone else got it wrong, is because we considered a lot of social science dimensions and components to what was happening at multiple different levels. And if social scientists are armed with good data skills, they're hugely valuable, absolutely hugely valuable to this kind of public health work. We have one job posting that's out right now. It basically is a combination of an epidemiologist, a public health person, and someone who can handle data. So something like that, the main consideration in finding people like this is if you can find a unicorn that has good data skills and good social science skills, you want them on your team. Absolutely, 100% of the time.
That's great. So dovetailing off of that, Zach asked a question about kind of sort of getting into the field. I can vouch for Zach. He's a data guy in our team and he's phenomenal at data, but doesn't have any background in epidemiology or anything health related. So how would a data person, either in traditional or non-conventional ways, get exposure to or learn more about health and healthcare from the data side?
Yeah, so that's a great question. You could, you could do something like get a Master of Public Health, which is a terminal degree, or a PhD in epidemiology. Those would be ways directly to go into the field and learn what the canonical building blocks are. That would do it for you. There's other ways to do it. So my route was not that traditional. My degree is not a health degree. It's a math degree. So I have a PhD in applied math. I happen to work on problems in epidemiology modeling as a subset of population dynamics. But when I finished my PhD, I decided that I did not want to do traditional academia. I did not want to go do a postdoc just doing pure math. So I took a job with the Rand Corporation and got involved with some bioterrorism stuff, and then returned to ASU in 2005. I worked for the Decision Theater. I did modeling there, and I built up the portfolio in health and infectious disease dynamics. And I took a little bit of what I knew, but really I had a lot to learn, and I learned it like on the job in real time, just hands-on with the data. And my ability to handle data got me through a couple of successful projects that I didn't know as much about the public health, but I knew enough about disease transmission dynamics that I could fake the rest until I learned it. And then I landed in a very influential central role in the federal government where I learned everything about, bioterrorism response and whatever. So for you specifically, Zach, or anyone else that has the same question, ASU does not have a public health program yet. We do not have an epidemiology program yet. But I would put our team up against pretty much any public health preparedness team in the country at this point because of who we have. We're a very small but mighty team. We have a lot of experience here. And if you're interested in doing projects, we have a number of different projects that we work on a regular basis. So just have a conversation with me and we can introduce you to the group. We're a friendly group. It's an open invitation to everyone here who's more interested in learning about what it is that we do and how we do it. And if you want to participate in it. I mean, I joke all the time that, up until 2018, 2019, people were still publishing papers on the 1918 flu pandemic. So if you think that COVID is going away and there's not an opportunity to do research or modeling work in this area, you're dead wrong.
That's great. Yeah, I joke. Everyone doing models is going to have to put a little asterisk by 2020, 2021, right? You do this sort of 10-year and you're going to have these weird sort of spikes and discontinuities in 2020. So yeah, it's going to be around for a while.
Yeah, but I mean, keep in mind, like the last serious pandemic that we saw in this country was 1968. 1968 and 1969, we had a very serious flu pandemic, and that was the height of civil unrest. So if there's one year that history can teach us something from right now, it's that.
Yeah. Josh and Jennifer had questions about sort of data collection, analysis, aggregation. Josh is saying, how has, in the epidemiology space, has data collection, integration, aggregation gotten better or worse during all of this of 2020? Jennifer asked, how did changes in reporting to the CDC impact our ability to combine and analyze hospitalization data? So what have you seen as sort of our ability to collect, aggregate, integrate data through this?
So this is, I'll give a short answer, but this is a very long, complicated issue. I've spent a lot of time at the CDC working with them on data issues. There was actually a really nice story in the New York Times that was written this summer when the federal government attempted to move one of the mortality reporting systems from a CDC office to an office in the office of the secretary in HHS. That move backfired because colleagues were upset enough about it that they basically leaked the story to New York Times, and New York Times covered it, and that data set has since been moved back to CDC. The reason that's important is because that was a political move, and it was not going to lead to increased data quality. It was going to lead to decreased data transparency. For the most part, however, CDC has a number of data systems, many data systems. They're not all interoperable, but they are all complicated. They have mandatory reporting categories that rely on states collecting data from providers and then states sharing that data with CDC. It's not CDC's data, it's the state's data. So CDC does not always or even often share that out to the research community publicly. Some data categories they do, like if you look at ILI, influenza-like illness, there's an ILI reporting system, an ILI net. There's also something called the reportable diseases. If a clinician gets a disease that's on a list of reportable diseases, so things like plague, coronavirus is on it too. All of the reportable diseases come to CDC. I believe it's either a daily or a weekly basis. It's like a requirement for it to be weekly, but they try to report it in real time. So those systems are there. They're just not as accessible as people think, and they have the same problems that people have in collecting from providers. Some are great, some are not. Some diseases go undiagnosed. So what really has happened is over time, I think that we have moved to more and more sophisticated systems as the rest of the clinical and surveillance community is able to upgrade these systems and as software is developed for them. They're not perfect. They don't receive huge investments, but they do receive, a good amount of funding. It's just, it's not a great technology space, right? Like you don't have the same opportunities that you do in AI or big data or anything that's like really, hot right now as a technology field. It's just large SaaS relational databases with Tableau sitting on top of it to constantly report volume of health data. And almost all health data is entered in by recording physicians, and they don't always do it the same way. They don't always have good training. A lot of times, if the system is doing something unfriendly to them and they have to get the data in, they'll just put in whatever information or data values make it seem like it's going to go into the system. And then someone at a state health department has to process that data. They have to review it. They have to sign off that it's entered correctly and accurate, or they have to go back and call the entering physician and try to figure out what's going on. There's like 20 different ways that COVID deaths can be reported, right? Whether or not it's attributable to COVID or caused by COVID or tested positive with COVID. There's different outcomes from that determine how that death certificate is going to be entered into mortality case counts. So when you have a pandemic and you have a lot of cases, a surge in cases like this, that's all time, right? You're taking the entire health department and you're basically saying, you four continue to try to do your day jobs and keep, the system running for all other diseases and, smoking cessation and obesity and, mental health and, the rest of us are all going to go and work 16-hour days on COVID. And they have a number of data scientists who basically do that on a daily basis, and they try their best and they're good people. It gets worse during a situation like this, specifically because the volume of data that has to be processed and entered and the demands on their time are so intense that it can lead to a lot of poor reporting and inaccuracy or delays in reporting. There's also there also can be political considerations when reporting data. I'm trying to think of the nicest way to say this. If if a subset of data were held back for a couple of days, and then entered into the system, that wouldn't necessarily be malfeasance or anything like that, but it could skew the numbers in a more favorable or in a less favorable way if someone was aware of how to do that. I think that's, it's really universally true for all of these data systems, which is that there are many humans in the loop that are required to keep the data on track and reporting what it is supposed to, whether it's in the US or other countries. Not being able to test or deliberately not testing, those are two very different things, but they're going to have the same impact on the data. Delays in data because you can't get a test result back for 14 days, you're not going to see the increase in prevalence that you're experiencing in the community now from health data for another 14 days. Like, you have to wait until the test is complete and the data comes in. That can be horribly misleading, but if you know that fact, you can also try to find ways to adjust for it or adjust for it. So yeah, and these are exactly the issues that we were experiencing on April 29th. That's why the case study of April 29th is so interesting, is because everyone got it wrong except for us, because we knew the data was incomplete. And if people had just said the data is incomplete, they would have understood better to think about what is coming next and why is the data saying what it says today, instead of just taking it at face value.
That's great insight. You, in what you just said, you mentioned reporting deaths, attributing that to COVID. Dixon had a question about mortality data and all-cause mortality rates. He's looking around and having trouble finding those, but is mortality rate a good metric, or is that too fuzzy, or because of how it's reported, or also that mortality isn't the only outcome of COVID? So what's your feeling on that as a measure?
Yeah, so, okay, so I see the pyramid in here. Pyramid's a good way to look at this, right? It really is. So this is like, there's layers here, right? You want to understand each layer separately, and then you want to understand them in context of each other. So all-cause mortality is up. It's been up this year. It's considerably higher. And there's also time delays on the reporting of mortality data. Some data has to go to the National Center for Health Statistics and be approved by the CDC and then reported back to the state. So if you were, so there's always an examination of the death certificate. If you report that someone has a positive COVID test, they're in the ICU, they die from COVID, that's going to immediately be reported, right, within a day or two. But there's other things that require investigation. And keep in mind that we originally didn't understand the symptoms of COVID. It took us months to understand things like stroke, heart attacks. There are a number of coagulation issues where blood starts to clot more quickly and inexplicably. That is what causes strokes or other conditions with that. There are heart conditions that can become permanent. So there are a number of unfortunate cases where someone could have died at home of a stroke or a heart attack. Once they're identified, they get picked up by an EMT. They never actually are cared for by a doctor. They might go directly to a morgue service. And it could be recorded that they die from a stroke or something else, right? So that's an example of a COVID death that could be completely unreported, even on a death certificate. It's a little bit easier now that those disease outcomes and those disease progressions are known clinically, but it's not perfect. So you need to look at the backfill. You need to look at the current case counts. We actually do. We have a process that we invented that relies on hospitalization data and death data solely in order to estimate current numbers of infections. And we don't even look at the case data at this point in our model. We basically have a backcasting process that takes hospitalizations and deaths, rewinds it in time, comes up with a plausible beginning state in terms of infections, and then run that forward. And that's the whole foundation for us being able to handle unreported tests, or unreported cases rather, because someone didn't get a test. So, in a few years, we'll know. But it's not something that's really going to be solved within 5 years. It's not something that's going to be solved within 30 years. We're never really going to have, a machine that tells you the exact cause of death, right? That machine would probably look like the device they use in Star Trek, where you go into an emergency room on the spaceship and they have exactly one instrument, and it's both a computer and a medicine. So that's just kind of it.
Yeah, it's interesting. I've always said, education and healthcare are very similar. Did someone learn? Why did they learn something? When did they learn? It's the same thing about, are you sick, or what did you get sick from, or how did you catch it? It's really hard to kind of get that causality down. So there's lots of parallels in that kind of research.
Mm-hmm.
A couple of pragmatic questions. Kamal asked, reinfection. How common do you think reinfection is? Are there any concerns about mutations?
Yeah, so we don't know. We don't know the whole story on reinfection yet. We know that it's possible. We know that there are waning antibodies. We know that there are other diseases where people have waning antibodies, like actually most of them. Even something like, like chickenpox, reappearing as shingles. It's just waning antibodies. So what we really need to know in order to deal with waning antibodies correctly is a longer time distribution of when antibodies wane from a variety of different population subgroups. I expect that very few people actually have waning antibodies where they, 6 months later, everything is gone and you get sick again. There's something that just seems to be, from an immunological perspective, and I'm not an immunologist, but it just seems to be off to assume that. What you see from influenza and other diseases is that there's a period of time that it takes for antibodies to wane, that it could be from months to years. It's going to be different for different people. It could depend on genetic predisposition. It could depend on how severe the disease is when you get it. It could depend on soon whether or not you got a vaccine and which vaccine you got, because those also are going to be, medicines that generate antibodies. And so if the antibodies from the disease wane, you might see something where the antibodies from the vaccine wane too. That's not a surprising situation. There are several vaccines that require booster shots. So COVID also could, require a booster shot every year. And then there's multiple vaccine manufacturers. So we don't know yet what happens if you take a Pfizer vaccine and then you take a Moderna vaccine, because clinical studies are only done on one or the other at one time. So a lot of issues here. The fact that it's the antibodies do wane, and we have confirmed cases of people who've gotten it a second time. It can be worse the second time. That's similar to diseases like dengue or Zika, where prior infection just makes subsequent infections worse, not better. So this is this is a situation that, here's scientific evidence that COVID is going to be around for a very, very long time, supporting what Lev said this morning. There is no post-COVID world. There, if you look 50 years into the future, we're probably going to have dealt with it in a variety of different ways where we don't have to exercise strict public health measures on a daily basis, but it doesn't mean that it's gone. It just, it probably just enters the viral ecosystem that we live with every single year, that includes a number of influenzas, a number of coronaviruses, and several other types of infectious disease that, that are all things that we have to be mindful of and deal with.
Yeah, great point. Nicole had a great question about double reporting. So if you get tested 2 different places in a similar period of time, do those get filtered out, or do they get counted twice?
Yeah, they get filtered out. So especially in a hospital, you get tested multiple times. For positive cases, you want to get tests to confirm that you no longer are shedding virus. Those tests aren't that useful because you're generally going to test positive when you have basically viral fragments that are not viral, that are not capable of replicating. So they're not viable as a complete virus, but they will show up on a PCR test. And so the algorithms that are developed for reporting will remove all of those duplicate cases.
Got it. Similarly, you mentioned the antigen tests in those couple of days where they were added in and then stopped. Are they still being added, or antigen tests?
They're reported separately now. Just a separate category.
Probably makes it easier. Had one question about transmission and transmission through clothes. So like, should I change my clothes and wash my clothes every time? Like someone, SB was looking on the CDC website, and any thoughts on that, or what have you heard or seen, Tim?
Yeah, I haven't heard this one before. I would say that there might be different considerations here. I don't think, I mean, if you're waiting tables or working in a store or some kind of frontline worker, it's probably a different situation than if you're sitting at home pushing buttons on a computer like I do mostly. But there may be other considerations other than COVID, like maybe it's just a good idea to change your clothes every once in a while and wash them when you do. The good news is you can't smell anything through Zoom.
Josh Consalvo had a question, a timely one. Looking at campus planning, did you take sporting events into account with people coming to campus and other folks? I mean, obviously that's changes by the week, but is that part of any planning for campus modeling?
So the answer is no. We have not incorporated athletics into campus modeling. We run the testing program as the random sampling program. That's what we do. I'm a huge sports fan. The prospect of bringing a bunch of fans back or modeling practice, it's going to be different for everyone. And I'm not sure that you really, that's the kind of micro level modeling where you'd have to put a location device on someone and watch all of their individual contacts in order to have predicted models. And it's my view that we don't need to have that level of invasive surveillance in order to manage the disease. We just need people to have best practices and put a program around the athletic programs themselves, which, I see lots of evidence is being done well.
Good. So a couple other questions have come in. I don't know if Tim, if you're checking the Zoom, but if you want, do you want to look over the last 5 or 10 questions there and see if there's any ones you want to address? Some good ones in there. We've got about 5 minutes or so left here, and would love for you to sort of drive what looks interesting there.
Yeah. Okay. Beta distribution is easy. I think I probably said a word, mispronounced it. We don't choose. I didn't say that we need to choose a beta distribution for antibodies waning. It's just knowing what the distribution is. We need to know what the distribution is. Are mRNA vaccines safe? So they've been developed for other diseases. Moderna is the company that's making the leading mRNA vaccine. They're very popular within the biomedical community right now because they have the ability to enter into a cell and replicate more easily. So they're I would say that they're promising, and I would say what's really important right now is that the FDA be allowed to conduct these clinical trials with the level of scientific credibility that they expect to work at. As long as that happens, no vaccine is 100% safe, but the FDA trials are going to be run with a level of scientific integrity. And then ASIP, which is the vaccine board that runs out of CDC with the scientific community providing input, will watch for those. Generally with vaccines, what you see for an FDA approved vaccine, very, very few and rare adverse events. Even if there's 1 or 2 adverse events, they can shut down the entire trial until people figure out what the adverse event was caused by, how likely it is to be, and other criteria around it. So I think it's, in all likelihood, its safety is going to be well understood and fine when it's released. Its efficacy is still probably unknown. And the question is whether or not people would want a vaccine that's 60% effective as opposed to 80 or 90. What's the threshold there? And if it's a completely safe vaccine with a 60% threshold or a 60% efficacy, that's probably going to do a lot of good. But it doesn't mean that everyone is completely protected. So these considerations are really important. All right, the racial data tracker, I don't know anything about. It sounds like has a terrible name. If there's a data tracker that includes voluntary race information, that's a very different thing. But the COVID track. Oh yeah, okay. I have seen this. I would have to look back at this. It's been a couple of months since I looked at that particular web page. I do remember reading it. So the issue there is that the intent of that web page, as I understand it originally, was to look at differential outcomes for different racial communities, because most of the early studies on this demonstrated that COVID disproportionately affected Latino and African American people and Native American people. I don't know that they've offered a justification for that other than they tend to have higher contact rates. They tend to have re-entered the workforce more quickly. And they tend to have more multi-generational housing. So those would be the key issues there. There's serious issues, equity and fairness in all parts of the response are incredibly important. So there's a number of good projects that are trying to address those, including on the President-elect Biden's new task force.
Well, we can wrap it up there. I think we got through most of the questions.
Yep, sounds good.
Yeah, thank you everyone for asking questions. Hope we fielded them properly. Wonderful to have time with Tim to be able to answer that. So Tim, this is, I know for me personally, this is everything I hoped it would be. You are a fountain of knowledge, and especially in this day and age with what's going on, it's so wonderful to hear from someone that is just embedded and knowledgeable. So please everyone join us in thanking Tim for his time and for his valuable information. And in the days when we're walking around campus and you see him without the beard, you have to try to struggle to say, is that the guy? I kind of think that's the guy, but I'm not sure if that's him. Yes, thank you so much, Tim. Really appreciate it. And I am going to hand it back to Brandy and Samantha to wrap up for the day.
Great. Thanks, everyone.
Thanks, Mike, and thanks, Tim. We really appreciate all of your insights and being able to share the story of how you have conquered some very, very present data monsters in our world right now. So that concludes our opening day. Couple of comments and a couple of notes for y'all. Please see the asu.edu events data conference website for all of the programming and important links for the schedule of sessions that we will attend over the next several days. If you haven't already, please join our ASU data community channel in Slack. We've already got some very active folks there and love to continue the conversation with you. And then also, we've created a place to celebrate one another and recognize some of those great contributors and data fighters, data slayers, data monster slayers, excuse me. So if you would like to recognize someone in your community or in another department who has encouraged you, has helped you, has supported you in identifying and dealing with some of your own data monsters, we invite you to come up to this link, which I think is going in the chat. Erin, if you can drop that in the chat, I'd appreciate it. And submit your recognitions there. And we will be sharing those each morning when we come back here each day for our plenary time before we kick off our day and hop into those sessions. So we will see you all back here bright and early tomorrow at 9 a.m. for our plenary session and we will get ready to launch into a wonderful week of programming. If there's any questions, feel free to reach out to us on that Slack channel, and one of the planning committee will be sure to get back to you. And thank you all. Thank you especially to our presenters, and we look forward to seeing you over the next couple of days. Thanks, and have a wonderful rest of your day.